Hello, ladies and gentlemen. Welcome back to our ongoing series of lectures on anesthesiology. In this lecture, we're going to talk about the management of pain, which is an area of great passion to me. The focus is going to be primarily on chronic pain because we've already covered some aspects of acute pain. So our agenda for this lecture are going to include definitions of pain, some of what we know about the pathophysiology of pain, the various families of analgesics that are used to manage pain, the modes of delivery of those different analgesics, and then there are going to be 3 small case reports just to give you an idea of how management can vary according to the way a patient presents with pain. And then, because it's a very special area of pain management, and although we've covered it briefly in passing previously, I'm going to spend a little bit more time going over some of the details associated with management of obstetrical pain. So this is the Oxford Pocket Dictionary definition of pain. Strongly unpleasant bodily sensation such as is caused by illness or injury, mental suffering or distress. It can be a vulgar term as pain in the neck or other anatomical areas. It can be great pain, great cares or troubles. I have pain. And it can be idiomatic verb as to pain somebody, to pain something. In every language, there are literally hundreds of descriptors for pain. And this is an indication of how ubiquitous this problem is and how much trouble we have in trying to describe our discomfort. So the most important thing that I can convey to you in this lecture is the importance of the pain team. The evidence on treatment of chronic pain has shown repeatedly that the only model of treatment that works consistently is a multidisciplinary pain team approach to care. None of us individually, none of the disciplines by themselves are adequate to help people with chronic pain. The lead member of that team is the patient himself or herself, and included in this should also be the patient's family, loved ones, etc. Nurses, nurse clinicians, anesthesiologists, clinical pharmacologists, psychiatrists, physiatrists, physiotherapists, pharmacists, social workers, occupational therapists, radiologists, neurosurgeons, social workers, the family, as I've already mentioned, and pastoral care are all part of the pain team. With obstetrical pain, it's the patient, the partner, the coach, the midwife, the obstetrician, and the anesthesiologist as well. Acute pain, such that is caused by surgery or injury, can be managed by anesthesiology, but there should be access to the other professionals as well. And we've already covered some of acute pain. We'll cover a bit more again in this talk. But in honesty, most of the treatment of acute pain is over-the-counter medications such as acetaminophen, paracetamol, or prescribed medications such as opioids. The treatment of chronic pain is much more complex. The incidence of chronic pain is unbelievably common and is largely ignored in our societies. It appears to be independent of race, culture, economic status. And it is said that about 30% of adults have chronic pain at any given time. And you'll recall the IASP definition we gave in an earlier lecture that is continuing pain for 3 months. Some people say 6 months, but an extended period of time in either case. 12% of people have severe pain. So at any given time in each of our societies, 12% of the total country is suffering from severe pain. And 2% have such disabling pain that they're essentially unable to function. Disabling pain is more common than cancer or heart disease and more costly to the medical system or to the healthcare system than both cancer and heart disease combined. So pain neurotransmission, this is a simplified diagram just to give you some understanding of the process that the brain and the central nervous system go through in responding to pain and recognizing pain. So any kind of injury, peripherally, or any kind of sensation peripherally, is picked up by nociceptors. Nociceptors are receptors that respond to not so much injury, but to irritation, to almost anything that causes discomfort of any sort. The transmission is through the peripheral nerve to the dorsal horn of the spinal cord and going through dorsal root ganglion on the way to the spinal cord. It then is transferred to the opposite side of the spinal cord and up through the central nervous system in the spinal cord to the cortex. And the cortex immediately responds to that pain by sending messages peripherally to subdue the pain. So in essence, what the brain is saying is, okay, I know that there's pain out there, but let's turn off the excitement a little bit. Let's reduce the acuity a little bit so we can deal with the whole issue. So there's a constant modulation of pain that occurs at the brain level in the cortex, in the brainstem, in the spinal cord, and peripherally. So initially the pain can be very severe, and you've probably noticed this. Very severe when you first develop it, and then in a few minutes it's not quite as bad. It's still there, but it's not quite as bad. So modulation, which is this process of moderating the pain, occurs at all levels and is mediated by opioid peptides. We mentioned very briefly enkephalins and other naturally occurring narcotics in our bodies. Norepinephrine, which is a neurotransmitter almost everywhere in the body, certainly in the central nervous system. Glycine and GABA. GABA is glutamic aminobutyric acid, and for many years it's been known to be involved in pain, both pain recognition and pain modulation. But drugs that work directly on GABA seem to have little effect on pain perception, and we'll get to that in a few minutes. There are a great number of analgesics that are used in the management of chronic pain. We've talked already at some length about the opiates, and they're basically either drugs from natural sources, such as from opium plant, from the opium poppy, or their opioids themselves are manufactured drugs. It doesn't matter which they are. They act exactly the same way. And I'm going to use the two words interchangeably, as I already have in this lecture series, but I'll continue to do so because, quite honestly, I can never remember which is an opiate and which is an opioid, and it makes no difference in terms of the patient's condition in any case. Our brain has opioid receptors, as does the spinal cord. These are mu receptors, delta receptors, and kappa receptors. But the most important one is the mu receptor. And the mu receptor is both responsible for moderation of pain and response to pain, but it's also the receptor that creates all the side effects that we see with opiates. So what opioids and opiates do is they change the brain's response to pain. And it's interesting, if you talk to somebody who takes opiates, they often still feel the pain, but it doesn't bother them very much. And that's because their brain's been told to ignore the pain. So the pain in terms of transmission traffic may continue to be a very high volume situation, but the brain doesn't respond as much. So it starts to ignore the pain, and that's what opioids do. In the brainstem, opioids stimulate release of inhibitory signals. So this is part of that modulation process I mentioned. And this occurs also in the spinal cord and through what's called the primary afferent nerve, which is that first nerve that goes up to the brain. There are actually synapses along its route where inhibitory signals come in and kind of tune down the excitement. Opioids also work to some degree at peripheral sites and reduce the response to pain. So I classify pain in three ways, and that's not the typical way of doing it. Most textbooks and pain societies classify pain as either acute or chronic. And we've already talked about acute pain. This is severe, but usually managed with opioids, nonsteroidals, over-the-counter medications from your local pharmacy, local anesthetics. This is what surgical pain is generally all about. It usually doesn't last for extended periods of time, certainly less than 3 months in most cases, and is usually effectively managed by an anesthesiologist acute pain service. Chronic pain is longer lasting, greater than 3 to 6 months. It's difficult to treat. It's very difficult to treat. And it's associated with personality changes in patients and sometimes associated with drug seeking in patients. The other category that I've kind of created for myself, it doesn't have a clear definition, but I think is a very real situation. And this is the transitional pain, which occurs when acute pain isn't fully managed and it remains for a fairly extended period of time, and it transitions into chronic pain. And we know this actually exists, and we know that if patients are in this phase, and this phase can be days, hours, or perhaps even minutes, if we treat aggressively at that stage, we may be able to prevent the patient developing chronic pain. One of the worst forms of chronic pain is complex regional pain syndromes. Complex regional pain syndromes are a very confusing aspect of pain. CRPS is probably the commonest reason, other than headaches, that people see pain physicians. This condition used to be called reflex sympathetic dystrophy. It occurs in a transitional to a chronic form, and this is one of the conditions where if it's treated very aggressively in that, what I call transitional phase, can be treated and cured. It can be initiated by very minor insults, just soft tissue injuries, usually to the periphery, more commonly in upper limbs than lower limbs, but it can occur in either. And it's caused by peripheral sensitization resulting in what's called allodynia and hyperalgesia. So allodynia is the condition in which barely a breath of air causes severe pain. And hyperalgesia is pain that's much more extreme than the injury seems to indicate. So complex regional pain syndromes can be associated with very minor injuries. And I'm going to tell you a story from my own life, from the life of my son, my younger son, who was driving my car one day and was T-boned by a poor, confused lady who went through a red light and smashed into my son who was driving. He immediately had some mild pain in his left arm, and he had some difficulty with his neck. But beyond that, he really didn't have a lot of problems. We went to the hospital, he was examined. There were no severe injuries discovered. My son is a pianist. He plays the piano, and at the time this occurred, he was in university doing his degree in piano performance. And he needed to practice the piano anywhere from 4 to 8 hours a day. He discovered very quickly after this accident that he couldn't practice, that he had pain in his left wrist that not only interfered with his ability to practice the piano, but interfered with his sleep and was starting to cause some changes in his personality that were a concern both to him and to us. We had his wrist absolutely thoroughly investigated. It was x-rayed. He had nerve studies done. He had an MRI. He had a CT scan. He went to see a hand and wrist specialist, and nothing showed any acute injury. There was no fracture, there was no obvious damage, but he continued to have pain, and he was unable to play the piano. We worked very aggressively on using non-prescription medications. He was not given any narcotics, and physiotherapy, and over a year, but it took a full year, he finally recovered. That was about 10 years ago. He now plays the piano all the time. He has a very busy piano studio where he teaches students. And the pain is largely gone. It only occurs occasionally. But I think that gives you some indication of how devastating this injury is, complex regional pain syndromes. In the absence of any real damage that could be determined, he was incapacitated. He wasn't able to do what he was planning to do for the rest of his life. I'm going to tell you a second story about a young woman I was involved in the treatment of who had a minor fracture in her wrist. And she developed a complex regional pain syndrome that became increasingly severe over a couple of months. And it affected her to the point where her skin changed color, it became pale. She developed edema in her hand and wrist. She developed this allodynia. You could not go near her without the pain becoming very severe. This was a very stable, capable woman. She had a young family, she had a full-time job, and she was right arm dominant. She went through a very aggressive series of treatments, right up to the point of having what's called a spinal cord stimulator inserted, which is just about the most invasive thing we can do for pain management. None of them worked. She chose to have an amputation of her dominant arm to get rid of that pain. She had a minor injury. She ultimately, 2 years later, ended up having her dominant arm removed, and she was thankful for it. So this gives you some idea of how severe this problem can be and how devastating it can be to an individual's life. It's often associated with extreme sensitivity, that's the allodynia I've mentioned about, but changes to the central nervous system resulting in brain adapting to the constant pain, and what's known as neuroplasticity, where the actual functioning of the brain changes somewhat to modify its response to the pain. And we simply don't know what causes this, but it's a devastating condition and it's very common. Neuropathic pain is caused by an injury to a peripheral nerve. This can be caused by trauma, or it can be caused by disease. And we most commonly see it in people with chronic, often type 2 diabetes, but it can happen in type 1 diabetes as well. And it usually occurs in the legs, although it can occur in the upper limbs as well. And in this situation, if we look at the nerves microscopically, we can see there's actually deterioration of the nerve. And in those areas where there's been nerve injury caused by trauma, we can actually see regeneration of the nerve and kind of a shower of nervelets coming off the injured end of the nerve. And this can form a little nodule or nidus that's exquisitively sensitive. The pain that these folks have is flitting, it's shock-like. It happens completely unexpectedly, so they can't prepare for it. So we've already noted that neuropathic pain can occur in the presence of diseases such as diabetes and can occur after nerve damage, and when the nerves are examined microscopically, they do appear to be damaged. But it can occur with absolutely no underlying disease, and it can occur without any diagnosis whatsoever other than neuropathic pain. My wife, who is a completely healthy woman, has neuropathic pain in her legs and in her feet. For the last 3 years, she's been largely incapacitated by this pain. There have been periods where she's had to crawl up the stairs in our house because the pain was so severe she couldn't stand. The good news is she's starting to respond to therapy. The bad news is I suspect she's going to have neuropathic pain for the rest of her life, and all we can hope for is that treatment will make her more comfortable. Very, very difficult to treat, and it requires more than any single discipline to treat it. It needs physicians and nurses and all that whole pain team I mentioned to you earlier. Neuromodulation is one of the treatments. It's a late treatment. It's extremely costly. It costs between $30,000 and $50,000 to place neuromodulation systems in the spinal cord. This is the spinal cord stimulator. Very expensive, and it doesn't always work. When it works, it's a dream, but it doesn't always work and frequently doesn't work. So when it comes to chronic pain, a lot of the management of the pain is not to treat it or cure it, but to teach the patient how to live with it. But as I mentioned, neuropathic pain can occur with diabetics, but it can occur with no apparent cause at all. And the focus has to be on, this is what you have to live with. We're not going to get rid of it. You have to learn to live with it. It's a discouraging statement to give to a person. So in summary, in this lecture, we've discussed the complexity of pain, the various definitions of pain and the different types of pain, acute, chronic, and my transitional. We've talked about some of the treatment modalities for pain and how we approach patients with pain and how important it is to have a multidisciplinary approach to pain management and how we try to assist patients in learning to live with pain. We're going to have a second lecture on pain management that will go into more detail on the various drugs that are used in management of pain. And then we'll have some case summaries to discuss, and we'll follow that up with a discussion of treatment and management of obstetrical pain.